So today we will discuss about the incision part. Okay, so incision is the first step in full arch surgery after LA. Okay, so in incision there are three things. One is the basics of incision. Basics of incision means how to hold the BP handle, where to rest our fingers. This is the important thing. Without proper resting, trying to do the incision is the most common mistake. Only having a rest, finger rest, it will give stability to the incision. Otherwise, the incision, the BP blade may slip. Okay, so basics is important. The second thing is sequence. Okay. The third one is direction. In which direction you are making the incision. Sequence is different, direction is different. If you understand these three things, you will understand why we are making it more complicated, how it can be more simplified. Okay, we can master the skill if we understand these things. Okay, basics I am not going into deep. It is simple pen graph for us. Okay, and having a good stable rest, finger rest. It may be intraoral rest, extraoral phase rest. Okay, we can use the intraoral, some remaining teeth, stable teeth, or even the patient's ridge. You can keep the finger and take some rest, or you can use the patient's face. Okay, and not holding too close to the blade and not holding too away from the blade. This is also one more thing. Okay, now we'll come to the sequence. We will take the mandible as the example. Okay, so mandible, imagine this is a mandible. Okay, this is the tongue. Okay, now okay, that's okay. Now we will see the incision. We will make it red. Okay, so the standard incision is like this: one vertical incision, then a crestal incision, then again a vertical incision. Okay, so two vertical incision. Okay, vertical incision 1, then crestal incision 2, then again a vertical incision 3. Okay, so what is the sequence means? Which one will you do first? This one or this one or this one? This is the sequence. You can do any incision first or second or third. There is not much difference in it. But what is the difference is only if you follow a strict sequence, it will become a skill. For example, if this week you are starting the incision from here 1, 2, 3, and second patient you are starting the incision here, then you are doing the crestal incision from left, this incision, then you are doing this. Each and every time if you are changing the sequence, it won't go into the brain. It won't become a skill. ABCD, you have to write ABCD. One time you are reading ABCD, next time you are reading BACD, next time you are reading CDBA. You cannot memorize anyone. The brain cannot catch it. Okay. So first, to become a master in incision or flap elevation or alveoloplasty, in these three things, or even implant placement also, you should strictly follow the sequence. Otherwise, you cannot master it. It is your routine. I always do like that. You should have some. So what we are doing is, what I am suggesting is, okay, we are dividing this incision into 4 components. Okay, this vertical incision is one component, and this crestal incision till the midline is second component. This is third component. This is fourth component. Okay, or we will make this into ABCD. Okay, this is A, this is B, this is C, D. Which sequence you are going to follow? ABCD or DCBA, or A then C then D then B? Multiple sequence are possible. Okay, find out your own style and stick to that style. Okay, my usual style is, I will start from this. I will finish this part, this crustal incision, then I will finish this the second crustal incision on the left side. Okay, and then maybe this vertical incision. Okay, this may change little bit and all, but this will create a confusion. Now what I am suggesting is, first to do the vertical incision. Okay, second, continue the crustal incision. Okay, then third, finish the left side crustal incision. Finally you are going to place the left vertical incision. Okay, the logic is, this vertical incision is very, very important. If you make a crustal incision, then you are making a vertical incision, the blade is becoming blunt. The vertical incision is not very much proper. So flap elevation you will be getting difficulty. Okay, so do the vertical incision when the blade is fresh. Then you can make the crustal incision. Okay, then you can do the crustal incision from this end to this end. Then what you have to do is, you have to change the blade. And do the this vertical incision. You may be telling, I can use the one blade to maxilla and mandible and all, but having a proper releasing incision, it will make the flap elevation very much easier. The flap won't tear. Otherwise you will be wasting extra 2 to 3 minutes in flap elevation, elevating this part, and you may tear, bleeding will come. Okay, and healing will be delayed. All these things can be avoided by having a two blade. So sequence you understand now. Vertical incision, right crustal, left crustal, then finish the left vertical. Okay, so the sequence is over. Okay, this sequence you have to follow it again and again. Convert this as a SOP or a picture. Picture will be much more easier. Okay, ma? Name this as vertical incision CI. Okay, this is CI. Okay, vertical, this is more. Okay, now what is direction means? So each incision you can follow multiple direction. This V1 you can go from the crest to here, or go from the depth vestibule to the crest. This is the direction, in which direction the blade is moving. This crustal incision you can start from here, or you can start from here. This crustal incision you can start from here, this you can start from here. This vertical incision you can start from here to here, or here to here. Okay, sequence is different, direction is in which direction you are moving. Okay, so we will see each incision, the directions. Okay, we know that we are going to put this incision first. The obvious direction is from the crest to the vestibule. Okay, what is the risk of placing the incision from crest to the vestibule? Maxillary artery. The maxillary artery jumps from maxilla and comes to mandible. What is the risk of placing the incision from the crest to the vestibule? The risk of slipping. There is a branch of facial artery in the first molar area. Okay, so you should have control if you are coming from crestal to vestibule. Usually we do crestal to vestibule only. We don't do reverse. Okay. Now the question comes, that is why in standard incision principles, always do the vertical incision in the second molar. In the second molar, the facial artery loop coming is the chances of you are encountering a facial artery is very less. In first molar, the risk is more. But we still place incision in the first molar. Okay, distal aspect of the first molar. But we keep the vertical incision length very less. We are not going very deep. Okay, the reason why we are choosing the distal aspect of the first molar is elevation becomes easy. If you do the incision in second molar, flap elevation becomes very much difficult, and it's unnecessary to open from second molar and all. Okay, so the direction is from here to here. This right crestal incision is direction from here to here. It will come like this, right? Okay, but it will reach only till the canine lateral area. Okay, not even till the midline. Okay, it is difficult from our position. Okay, this crestal incision you are coming from here, because you are a right angle operator, you can finish till the 3-2 area. Okay, so joining these two incision, it becomes little tricky. One incision may be like this and another incision may be like this. Okay, this we should take care. Okay, the sequence right? This is the sequence for vertical, right vertical. This is the sequence for right crestal. It may not come till the midline. It is actually not possible. Otherwise, you have to stand very much in front. From the right hand side, actually you can finish the left crestal incision from here to even till the 4-2 region. Okay, then the remaining part is the vertical incision on the left side. Okay, here if you want to do from crestal to vestibule, you have to hold it like this. No, you are a right hand operator, you have to hold it like this and do it, which is difficult. Otherwise, you have to use the left hand from crestal to vestibule. Using left hand with blade is not advisable. Okay, so what I do usually is I come from the vestibule to the crest. Vestibule to the crest, not from here to here. Vestibule to the crest. What is the risk of coming from vestibule to the crest on the left side? Still the blade will slip when it is coming out of the crestal area, and it may injure the tongue. So control should be there. Whether you go from crestal to vestibule or vestibule to crest, blade slipping is always there. Vestibule blade slipping, it may lead to bleeding, facial artery. Okay, vestibule to crest, it may slip and injure the patient's tongue. So this sequence you have to follow each and every time. And of course, when you are doing the vertical incision here, you will be changing the new blade. So what I will do is, I will make the vertical incision with the new blade, and I will again reinforce the crestal incision here, because this crestal incision is done by the old blade. The blade would have become blunt, so the incision may not be proper. The incision may not be up to the bone. It may not incise the periosteum. If the periosteum is not incised, then flap elevation is difficult. Okay. So coming to the some challenges we may encounter in incision that we will see now. Okay. This is a cross section of the mandible. Okay. Okay. This is another cross section of another mandible. Okay. This is another cross section of another mandible. Okay. So this mandible incision is not at all difficult. This is like walking on a big road. There is no risk of slipping is there. You can easily walk. But the problem comes when the ridge is little thin, say 2 to 3 mm or 4 mm. I will draw the soft tissue. What if this is a soft tissue? Okay. Okay. This is soft tissue. Okay, here the soft tissue will be like this. Okay. So you are seeing only the soft tissue. You are assuming that the soft tissue, the mid incision will be the mid incision of the bone, which will easily happen in the bone is broad. Even if there is a 2 or 3 mm, you are still in bone. But here, if you start the incision from here, you may hit the bone. But if you start the incision from here, the drill will actually slip here. Sorry, the blade. The blade will slip here. The blade will slip here. Okay. So thin ridges, the problem is blade is slipping. Okay. For example, if it is, because you will be giving lot of pressure, because you are going to encounter the bone, because your brain is telling you have to incise till the bone level. So you have to give pressure. So you will give pressure and you will start incision here. But there is no bone there. It's only soft tissue. So immediately it may slip and injure the floor of the mouth. Not injuring the gingiva is not the problem. The blade slipping and injuring the floor of the mouth or tongue is the problem. Okay. So how to prevent this is, if this is buccal, if this is lingual, keep one finger here. Okay. Keep one finger here. Okay. It will compress the whatever gingiva and your finger will become close to the bone. Then you will get an idea. I am away from the lingual soft tissue. I am into the bone. Okay. Okay. So keeping one finger always. Even good bone cases, you can use the finger control method. Keep one finger lingually whenever you are placing the crestal incision. Crestal incision. Okay. So there is a way to keep the finger. Okay. For left side it becomes easy. You can keep the finger here and you can do here. But doing the right side, keeping the finger for control of the lingual side, it may be a little challenging. What I will do is I will hold the mandible like this. Hold the mandible like this, buccolingually, intraorally. Intraorally I will hold the ridge with this finger and I will use this finger as a guide to place the incision. If you see the surgery videos, you will observe this. Okay. So the blade slipping is there in any incision, any sequence. Okay. This is the incision, right? Vertical incision also it may slip. From crest to vestibule it will slip vestibule. Vestibule to crest it may slip into the tongue. This incision it may slip. If it is lingually it will injure the tongue and floor of the mouth. If it is buccally it will injure the soft tissues here. Okay, va? So anywhere slipping is a risk. So you should have a good control, brain to finger connection. You feel what the blade is feeling. You have to feel what the blade is feeling. The blade will tell you whether it is in the bone or it is not in the bone. Okay. So the incision part we have to do it very slowly. This is the step where we should not hurry. Okay. So coming to the very severe situation. very thin ridge kind of situations. Okay, here it is not at all possible to place the incision here. Okay, so what happens is in this kind of situation is there are only two possibilities. Imagine this is lingual, this is buccal. Okay, here the tongue is there. So either your incision will be like this, or either your incision will be like this. Either it will be buccal to the crest or lingual to the crest. If it is buccal to the crest, you have to elevate this flap over the ridge and come to the lingual side. Okay. If your incision is here, you have to move the flap from here to here, which is very difficult. Easy is to place the incision labially, just crestal to labial to the crest, and you can, with the elevator you can move this and bring it to the lingual. So flap elevation is challenging in knife edge cases because you cannot place exactly in the, it will be either little buccal or palate or lingual. Okay, we will see a scenario. Now close this. If you see here the ridge is quite thin, not very thin, but still if the soft tissue is very thick, soft tissue we don't know how the anatomy is, so it may misguide us. If it is misguiding us, we may slip. So if you keep the finger lingually, it won't misguide us. Definitely you won't slip lingually. You can slip buccally, but you will stay close to the finger because you know what is the lingual border. The ridge width is around 3 to 4 mm only, so you will know, you will place it tentatively correct incision. But the challenge happens when the ridge is like this. Okay. Okay, this is very thin. You may be thinking, no, I can do alveolar, but okay, for implant placement that is okay, but for incision itself we are having challenge. No? So exactly here you cannot place incision. Exactly this thin ridge is 3 to 5 mm. Either you can place here or you can place here. Mostly the incision will be slightly on the lingual side. So the lingual flap is quite easy to remove, but the buccal flap, no, you have to push this flap towards the labial. This is labial side, right? This is labial and this is lingual. So here you will keep the finger, but still you will be placing the incision little off to the crest only. Okay. The flap elevation you have to take time and do it. Otherwise the flap may tear. Okay. We will see some videos to see this. Okay. Especially in severely resolved cases, we won't know which is the floor of the mouth, which is the thing. So keeping the finger palpating, and when the blade is traveling, your finger also will travel. So for left side, you can keep the finger very easily like this. So how to keep finger for right hand side, we will see now. Okay, so you have to keep the finger there like this, and using that finger as a guide, you can make the incision. So as the incision is coming front, you have to, so use the finger guide always, whether it is a good bone situation or thin bone situation, it will become a habit. Okay. So here if you see, I am doing the vertical incision later. That means I am violating the sequence principle. Okay. Sequence and directions, it should be uniform. It is your own, it is your style. Okay. So, you are starting the incision from left hand side for this patient, right? So that means the sequence is, there is no proper sequence, means there is 1 2 3 should be there. The crested incision was placed, but vertical incision was not placed till now. Okay. So if you are jumbling the sequence, we can not become the master in that. Okay. You should follow the same each and every time, same sequence, same direction. It has to get boring. That means you are going in the correct path. Okay. If you are getting bored, then it is the correct path. See, the vertical incision, you are going from down to crest, right? The blade will slip superiorly, right? So follow the sequence and directions which we discussed. Okay. So the same principles can be applied for the maxilla. Okay. And the same principle can be applied for the flap elevation. So flap elevation, there is a basic principles are there, sequence is there, and direction is there. If you know these three things, then you are the master. Okay. Alveoplasty also, these three things: basic do's and don'ts, sequence and direction. Implant placement also. Okay. Basic do's and don'ts, sequence and direction. Okay. So we will stop with this.